going to review leukemias. I wanted to talk about leukemias because this will definitely be on the board exam. Neoplasms arising from hematopoietic cells, which are in the bone marrow, are leukemias, and they are usually associated with no direct cause. Incidence is more frequent in males. The acute classification, there's two kinds. There's the acute myelogenous leukemia, which is AML, and then there's the acute lymphocytic leukemia, which is ALL. So the AML is the most acute version, and it has a higher occurrence in population that's greater than 60 years of age. It is 80% of all the acute leukemias in adults, and it actually has a very high remission rate between 50 to 85% in adults. So the long-term survival for adults, again, adult, is the mainstream word here, is 40%. Now, the acute lymphocytic leukemia, which has the classic sign of pancytopenia with circulation blasts, that's really important to remember. The one thing about ALL to remember is all the labs are low. So you have like the low red blood cells, you have the low white blood cells, you have the low platelets. And there's more difficult, and this one is more difficult to cure in children. So they have a very high remission rate of 90% with ALL versus the high remission rate that adults have with AML. That would be another distinguishing factor. And then don't forget that the pancytopenia with circulation of blasts is ALL, and all the other labs are low. The chronic classifications, you have CLL, which is your chronic lymphocytic leukemia, and the most common leukemia that occurs in adults would be CLL. Again, the most common leukemia that occurs in adults, all adults, and then occurs at both middle and older ages, and then the median survival is about 10 years. Lymphocytosis is the hallmark. Lymphocytosis. So this is a chronic one. So anytime you have like white blood cells that are greater than 30,000, you really should be thinking chronic lymphocytic leukemia, CLL, because, and not sepsis, because that's really, really high, and it's definitely some kind of bone marrow complication occurring with that. So something to remember. And then the chronic myelogenous leukemia, CML, again, this is the chronic version. It occurs mostly in ages greater than 40 years of age. The survival is 65% of patients are alive after 5 years. And the Philadelphia chromosome in leukemia cells is the hallmark. Again, chronic myelogenous leukemia, CML Philadelphia chromosome. That's really important. And then lymphocytosis for your CLL, greater than 30,000. And then pancytopenia for your ALL, with it being more difficult to cure in children. And then you have your more adult remission rate being higher in AML. The leukemias that have general signs and symptoms of leukemias would be maybe they're asymptomatic, but fatigue and weakness, like a weakness where like a mom is so tired she can't butter toast. And then anorexia, generalized lymphadenopathy, and then weight loss. Laboratory diagnostics would include CBC with subnormal RBCs and neutrophils, and then it's an elevated ESR. You would see peripheral blood smear that comes back to distinguish acute versus chronic, but the bone marrow aspiration is what your actual diagnosis is going to be confirmed with. So again, peripheral blood smear can tell you the difference between acute versus chronic, but the bone marrow aspiration for leukemias is what is going to give you your confirmed diagnosis. Blasts or immature myeloid lymphoid forms, which suggest acute leukemia, will be found in that bone marrow for that diagnosis. The management includes chemotherapy, but allopurinol is a medication that you should remember that you should help make sure that your patient is prescribed that is getting chemotherapy on this. It's going to reduce tumor lysis syndrome, especially for those patients that are at high risk. And again, for the diagnosis, bone marrow aspiration and control the symptoms. Just wanted to also remember to point out hematopoietic cells in bone marrow is where this neoplasm comes from for leukemias. Next will be the lymphomas. Lymphomas are lymphocytic malignancies, and they're diagnosed by biopsying the enlarged lymph node that is being questioned. Staging 1 through 4, 1 is where the disease is located only one lymph node or a group, and the stage 2 is greater than one lymph node or group, but it's only on one side of the diaphragm, where stage 3 is lymph nodes or spleen involved, and both sides of the diaphragm are involved in this one. And then you will see stage 4, which is your last stage, and liver or bone marrow involvement. So that will be your 4 stages. The diagnostics and labs you'll see used, routine labs. And then we have the CT, X-ray, ultrasound, and the MRI that will locate and stage the disease. That's always very helpful. But again, confirmation is going to be with the biopsy and a histopathologic exam. Plan of care will probably include radiation, chemo, and bone marrow transplant. The 2 types of lymphomas that are on here are the Hodgkins disease and the non-Hodgkins lymphoma. Hodgkins, very important that you remember that 32-year-old male with some sort of cervical adenopathy presentation will be this lymphoma. So Hodgkin's disease. Also, making sure that you know Reed-Sternberg cells differentiate Hodgkin's disease to that 32-year-old male from the 35-year-old male who may have non-Hodgkin's lymphoma. So that is really important, is what I've been drilled. And then we have the non-Hodgkin's lymphoma, which usually is a viral etiology, often presents with lymphadenopathy, and it also has the most common neoplasm reputation between the years of 20 and 40. Less predictable pattern than Hodgkin's disease, so that's a differentiation with diagnosis. And there's advanced stage disease being apparent at that stage. So next we are going to review macroangiopathic hemolysis and thrombocytopenia, TTP, and ITP, which is lymphoproliferation disease. The TTP is the one where your clinical signs will show hemolysis, thrombocytopenia, fever. You'll see neuro abnormalities with this one, and then renal abnormalities. So important to remember that. And then secondary causes will include it being drug induced, or it may be a postpartum pregnancy issue, maybe an allogenic bone marrow transplant, or SLE, scleroderma, HIV. To confirm the diagnosis, you need to have a negative Coombs. Also, your platelet counts will be less than 20,000. Schistocytes and peripheral smear, elevated LDH will all confirm your diagnosis. And then the treatment for TTP is plasma exchange.